and I want to thank the Indian Society of Transplantation for inviting me, and also Sanofi for sponsoring the visit. Certainly the two talk that Bob gave and the one I'm going to give really are related in terms of trying to overcome barriers in the immune system to transplantation. And certainly antibody has been one of our main focuses, but as Bob mentioned, the T cells are also very, very important. We can't forget about them. Does this work? Or? Oh, okay, good. Okay, these are disclaimers. And this is my disclaimers. I wanted to mention that I have been, it's been a pleasure for me to be involved with Indian physicians for many, many years. And at Cedars-Sinai, we were and are, since the late 90s, renal sister centers for the International Society of Nephrology with many colleagues. And this is a photo that was taken, obviously, a long time ago, before I had gray hair. But it's, I mean, maybe some of you guys are in that photo, I don't know. But this was at Ames, and this gentleman that is there, you can see, he is a Nepalese gentleman. And at that time, they asked me to look at him, and he had proteinuria and rising creatinine, and a biopsy that looked like what we used to call chronic allograft nephropathy, which doesn't mean anything, but we now know is antibody rejection. So back then, we had nothing. You know, we used treat with T cell depletion, or IVIG was just coming along, but we've come a long way since then, and I want to discuss some of those issues today. Now, one of the things Bob mentioned, and I want to talk about this just for a moment, is induction therapy. Now, this is a critical component for desensitization and treating patients that are highly sensitized. One thing I think we all agree on, and certainly in the United States, is that if you're going to do desensitization or treat or deal with highly sensitized retransplant patients, you should use T cell depletion. And there are a lot of reasons for that. And certainly, if we look at the basic immunology of transplantation, you know, you have we have gone through all of this, as Bob has. We've worked on this for many, many years. The ABO incompatibility, I think this is where desensitization has really contributed a lot, because we were able to do these transplants that were once forbidden. HLA has been more of a problem, but I think we're getting there to tackle that. And then the DSA problem post-transplant, we want to prevent that. So if you look at this, you can see that there's a number of ways to go about allograft rejection. Certainly, depletion of T cells, B cells, antiplasma cell therapy. We'll be talking about that today, and then anti-T cell therapy as well. So, you know, thymo is really, from my standpoint, a very important drug, because we give it as induction therapy. It's standard of care, I think, at most centers in the United States, especially for deceased donor kidney transplantation. And, you know, we do, in the early 2000s, late 1990s, basiliximab came along, and it was really felt to be a very important drug, because it blocked IL-2, and IL-2 was felt to be the motivator of the or driver of T cell rejection. However, I don't have a picture, but one of I met this gentleman in 2013 named Shimon Sakaguchi, and talked to him at a conference in Osaka. And last week he won the Nobel Prize for describing Tregs, which we know are critically dependent on IL-2. So our thinking about T cells is really flipped, because we now know the effector cells depend on interleukin-7, and the Treg cells are low interleukin-7 receptors. And so if you block IL-2, you're going to probably make it worse. And I think there's been data to support that. So T cell depletion, I think, is important here. And then if you look at no induction, again, I think this is very obvious. You're going to have a lot more rejection, especially in patients that are deceased donors. And I think Bob showed it very nicely in his talk with the Xeno, that these T cells cannot be ignored. Well, antibody rejection is something, you know, in the first slide I showed you, you have this patient, we didn't know what it was, and for many years we didn't know how important it was, but data from Lupi and colleagues and others in the United States have shown that it now accounts for about 50% of graft losses overall. So we had a cold water in our face about this. You know, what is happening here? Why are people developing these antibodies? And in general, we think it's inadequate immunosuppression overall in people intolerant of tacrolimus-based therapies. So, so this has really given a lot of interest in driving new therapies in this area. And this is a paper we did several years ago with Mark Haas. We looked at 80 patients with antibody rejection, and we defined them as type 1, type 2. And the type 1 is pre-transplant with pre-existing HLA antibodies, and type 2 is more of a chronicity, or what we call transplant glomerulopathy now. And you can see, maybe surprisingly to somebody or to people, that those that have the chronicity do much worse. And that's because they have a time to evolve a slow grind on the kidney, and it goes away. We also showed that, and this is early on, that if we could move the antibody down, they do much better. That may make sense, but to show it, I think, is important. So antibody reduction therapies is critical in treating and preventing antibody injury. So let's talk about the immune pathways that are important here. And there's some really great stuff. I don't have time to talk about this today, but just to mention it, there are two papers. One is a review, and that was in Nature reviews last year by our group. And then one of my colleagues, Sanjeev Kumar, who's a wonderful guy, he's a real savant in ischemia reperfusion injury, looking at this paper that he did with Pietro Sippa, who's in Switzerland, that late B lymphocyte action and dysfunctional tissue repair in kidney injury and transplantation. This is a great paper and gave us a lot of good ideas. And this is a paper that they published a few years ago in Nature Communications. Basically what they found, looking at protocol biopsies from patients who had ischemic injury at time of transplant. Over here on the left, you see there's a progressive increase in, when looking at, I should mention, bulk mRNA analysis, genes for B cells and plasma cells. And that correlates, if I can, right here, I think I can, yeah, whoops, my fingers, with declining GFR at 12 months. So here is the nexus, I think, for antibody rejection and ischemic injury, that you initiate a severe immune event, shown over on the right side there. And interestingly, Dr. Kumar's work in just native kidneys, where you give them ischemic injury, they develop the same B cell infiltrates. So this is a very potent stimulus, this ischemic injury to kidneys. And so, and in the left-hand corner up here, I'm going to show you, I've changed my antigen presenting machinery thing to a much more sophisticated one, based on information that we have regarding the, we just had a paper in AJT this month where we show that with Dr. Nick Chung at Mount Sinai in New York City, that when kidneys or hearts in his model are put in with ischemic injury, they just spew exosomes that are complement coated and have HLA molecules in them, and it goes to the spleen, all over the body, and stimulates the immune response. So we think this is what's happening in humans too. In fact, we know it is because we looked at our clinical trials with C1 inhibitor for DGF, and we can see these exosomes there, and if we treat with complement blockers at the time of transplant, they're not there, and they don't activate the immune system. So anyway, I won't spend too much time on this because we have you can see that the cytokines are important in activating B cell responses and plasma cells. So where's the attack options? Well, there, as Bob mentioned also, innate immunity is important here, where we have ADCC, or antibody-dependent cellular cytotoxicity, and also complement-dependent cellular cytotoxicity. B cell anatomy is very important here in choosing targets as well, because if you look at where the targets are expressed, we know CD20 is limited, CD19 goes all the way across, but only 50% of the plasma cells have it. CD38 and BCMA, or B-cell maturation antigen, are good targets for plasma cells. So anti-cytokine therapies, anti-NK cell therapies, anti-plasma cell therapies, and then antibody therapies, getting rid of the antibody. We're going to talk about that. So we have made progress. So if we look at an important drug that has, we think, I know Bob, we worked on this so hard for so many years, is imlifidase. We think it will finally be approved if the FDA trial met endpoints, so we think we'll have this drug. An enzyme that cleaves IgG in half and gets rid of the Fc fragment, so it doesn't give CDC or ADCC. This original paper that we did, we can show if you look at those HLA type or profiles from Luminex, see it gets rid of all these antibodies very quickly within a few hours and allowed us to transplant patients. I won't spend too much time on this, but one other thing down in the right corner here is that if we desensitize first and use some desensitization after, we prevented rebound antibody. This is data from earlier studies showing that you can, up in the top, that those 99.9% CPR patients, we can transplant them and they can have good 3-year graft survival. We now know 5-year graft survival is very important as well. From 5 years out, we can see that 90%, and these are all 100% patients, or 94 to 100%, 82% graft survival with GFR of 50. So this is something that is really good and will help us transplant these patients and have them get off dialysis. I'm going to skip this one. So here's the thing. Makes me feel really good. I know it makes Bob feel really good too. 12 months of the clinical trial from FDA, eGFR 51.5, and those in the control group 19. Yeah. And I don't know if you guys like martinis, but I had one for that one. So, so imlifidase is going to be an exciting breakthrough, and it's going to be the first new drug approved in the U.S. Since belatacept. So we're really excited about this, especially for treating antibody disorders in this patient population. IL-6, I've been really interested in this and still am. I think there's still promise for this drug as desensitization and also for therapeutics for antibody rejection. We know in kidney dialysis patients, IL-6 levels are very high. We showed this many years ago, and also CRPs. In fact, one of the drugs that we worked with, the clazakizumab, is now being looked at in dialysis patients in the United States to prevent cardiovascular disease mortality. I think this is a great slide, and there's a study that we just finished, or where I worked with a heart transplant group, because we can see that, and this is Jordan Pober did this in Journal of Immunology several years ago. If you can see on the top, that's a coronary artery from a human in a humanized mouse model, and you can see that they get the coronary artery vasculopathy. In figure B, you can see that those endothelial cells are expressing IL-6. Look what happens when he gives them anti-IL-6. You improve the vascular disease. So this trial in heart transplant, now done, we'll know more about it later this year, 200 patients, placebo-controlled, given Actemra for 6 months to see if we can prevent this coronary artery vasculopathy. This is the first study we did back in 2014 showing IL-6 could really, blockers could really prolong graft survival and patient survival, because these people go back on dialysis who are highly sensitized and had antibody rejection. Desensitization, it also works well in terms of lowering antibodies. And what we saw with in the lower panel here, increasing the Tregs, which we think we want to do, right? We don't want to suppress Tregs. We want to, and these patients have less rejection. I'm going to skip this. The data here in a clinical trial or phase 2 lead-in trials that we did and the group in Austria did show benefit. However, the phase 3 trial did not show good data because they cut the dose in half. But here's more recent data from Noble and colleagues at in Europe at Grenoble and I think at Genoa in Italy. 65 patients. You can see that 1 year run-in, GFR decline was really sharp in these patients with antibody rejection. And they were both C4D positive and negative, and DSA positive and negative. But if you look at the treatment with tocilizumab, very, very significant improvement in GFR decline over that time. And we have a paper just, it'll be out soon, showing exactly the same thing. We have 85 patients with toci, and you can see the decline. The GFR was declining at 0.7 cc's per month, now 0.07. So this is a good drug for chronic antibody rejection, I think. So I'm going to skip this. We talked about this. In the last few minutes we have, I want to talk about some of the things that are coming, regulating the half-life of IgG. I'm going to go through this a little bit quickly because for many years I've been working with IVIG, but you can see that IVIG has many proposed mechanisms. Most were not correct. We think that in this paper we showed that when we gave patients IVIG high dose on dialysis with this complement blocker, that the half-life of the IgG quickly dissipated, and the complement lost effect. So IVIG is controlling the half-life of this. And it's through this mechanism. This man back in the 1950s wrote a paper about the route by which passive immunity is transmitted from mother to the rat, and what it is FC mediated, and it's FC receptor neonatal. And there's now a drug called efgartigimod in the US, which we're going to be using to block the recycling of IgG, so the pathogenic IgGs go away. And I'll just skip this. And this is a trial we're doing now in antibody rejection to treat it with this, to get rid of the antibody. Another one, this is, we worked with IVIG very early on. And what I wanted to show you is that this is one of their first papers in '94 showing it blocked HLA antibodies. And our trial, which we showed could improve transplant rates. This paper just came out in Kidney International last month, where IVIG was used to treat antibody rejection. You can see the protocol there. Look at this. Just over many months, you can reduce the inflammation and improve GFR and patient and graft survival as well. So this is very interesting, especially for people who are immunosuppressed. Plasma cell therapies, we think daratumumab, anti-CD38, is going to be very good as a desensitization agent. This paper showed treating antibody rejection is excellent. It knocks out NK cells. So here we're having NK cells removed instead of reducing antibody, and this controls the process. This is an antibody we're working with. It's a bispecific antibody to BCMA and CD3, brings the two cells together. CD3 kills the plasma cells. We've transplanted 7 highly sensitized patients at our center on this protocol. We think it could be very useful. And I'm going to just show the CD40 ligand. I think this is my last thing. CD40, as Bob mentioned, is an important target for co-stimulation and induction of antibodies. We had a patient many years ago that had CD40 knockout, and I'll show you that. You can see he has no CD40 ligand on his cells, and he had to come up for a liver transplant. We worked him up and showed he had very severe T cell deficiency as well. So he didn't need much tacrolimus. And so that suggests that these antibodies to CD40 ligand can be useful. And there is a study starting in the US for treating patients right out and get them off CNIs, which I think is very important. So there's a lot of things coming. Here are a lot of the treatments, and we think that they all will find a place. And I think we're a long way from that photo back in 1997. We have a lot of tools now, and I think that hopefully we'll improve outcomes and allow a lot more patients to be transplanted. And this is one of our first imlifidase patients. It really makes me feel well to see this happen, that we can transplant people. She has a family now. And I think the most important thing we can do is give our patients hope for a better life and for them and their families. And for all the young people here, stay curious and always challenge things. So that if you don't do that, I think we're not going to go anywhere. So don't be afraid to take a chance on something. Thank you for your attention. I appreciate it. you.